Welcome back, clinical problem solvers, to another special VMR edition, the best one of the week. May I say, in my unbiased opinion, RLR. Robbie, how are you? What are you eating, man?
Oh, you want to see? Look at that.
Oh, wow. Did I tell you we finally made acai from the
Yes.
machine? It was
Yeah.
delicious.
Yeah, really?
Really, it was. So
Oh,
thank you for that.
you're very welcome. And I
This
appreciate the 3.5 month delay. I my ego is only mildly bruised, but not
dude,
not
I remember that first week you sent that machine to my house. You were every day sending me videos and asking me how is it, but then after a week you stopped. But it's in good use now, my friend. So I know we have a special guest presenter, VJ. Do you want to unmute yourself? Tell us a few words about how your day is going and what's on your mind.
Yeah, hi everyone. This is Vijay from India, CP Solvers member. Back to present the case. I just finished my shift and had a few interesting patients. I just reached home and excited to present the case.
VJ, we're so glad and thrilled to have you again. You do make me nervous, to be honest, because I think the last time it was a struggle, VJ. But we'll do our best. Who is teaching today? Who is making the teaching points?
I will do the teaching points today.
Say a few words.
Yes,
Julia.
hello, it's Julia. I'm a medical graduate from Germany, and I'm very lucky to get here in time because like all the streets are blocked because the Turkish president is coming to Berlin. So now it's fingers crossed that I got here on time. I'm very excited for the case. And yeah.
Are you a cyclist? I see a bicycle in the background.
Well, I'm more a runner. Well, I love both. But I guess I'm more a runner than a cyclist, but I do like cycling a lot.
Do you run every day?
Yes, I do.
Okay, so you're like Robbie. Robbie runs every single day. He's quite the runner. He's training for a half a marathon. He wants to embarrass me. And so he's been dedicating his waking hours to running.
Yeah, I dedicated for a marathon in 1st of December, so I've got to keep up
Wow.
with my training.
Where is the marathon?
It's in Valencia.
Wow, in Spain.
Yes.
Awesome. And who is doing the scribing today? If you don't mind, unmute yourself and say a few words.
So hi everyone, this is Johan. I'm an IMG from Cameroon and I'm scribing today.
Johan, when I see you, all I can think about is you holding on to that family history, but Robbie forcing you to reveal it, which led to the diagnosis. Welcome, Johan. Do you have what time is it where you are right now?
So I'm in Barcelona right now and it's 6 p.m.
6 p.m. Okay, that's early in Barcelona. Dinner time is what, 9 o'clock there?
The last time?
No, dinner time, supper time is 9 o'clock.
Oh, it's dinner time. Yeah, 9 o'clock.
That's what I thought. That's Robbie's bedtime by past 30 minutes. Okay, guys, all that being said, really excited to hear from Julia, Johan, and VJ. The mic is yours for the mathematician to tackle the first aliquot.
Guys, I feel like that was a whole production of an introduction. I think Progress is already tired, yo. So Vijay, you gotta take it easy on us.
So I'm presenting, this is a 46-year-old lady who comes in with history of fevers for 20 days. So coming to the HPI, she presented with history of high grade. She says there is history of high grade fevers and chills with recent onset of dry cough. And there has been shortness of breath for the past 3 to 4 years. She has noticed the worsening for the past 20 to 30 days, such that she is unable to perform even daily activities. So there is no chest pain, palpitations, facial puffiness, reduced urine output, no history of rashes, no history of joint pains. Review of system is fairly unremarkable for anything else. So I think I'll stop at this.
Vijay, this is such an intriguing combination of symptoms that I'm not sure I've really encountered before. And I think it just goes to show how powerful the sequence of events is to analyze the circumstance. And my current understanding of this symptom complex is that the patient has had long-standing shortness of breath for years. And what's punctuated that narrative is a more accelerated phenotype that is in keeping with that shortness of breath, in that non-inflammatory shortness of breath is accompanied by a reduction in her exercise tolerance in a manner that's not necessarily unpredictable. Really, most people who have chronic shortness of breath will ultimately have a crash landing and have their symptoms progress to exertional capacity that you are outlining, either as a result of a flare of the underlying disease that they have, or as a result of an acute superimposed complication. And I think it's quite the twist to have a fever for 20 days, because I think that of those two options, if a disease has been non-inflammatory for years, the probability that it suddenly mutates and evolves into an inflammatory one is less than the probability that it is punctuated by an acute superimposed flare or a separate disease process. So I think my mind would be honestly trying to separate these two things out to make sure that I'm not creating a false narrative, because probabilistically speaking, it's unlikely for one disease to suddenly become inflammatory over 20 days after having been so bland for a long period of time. And so I think maybe what I can do is just sort of reflect on the diseases that cause subacute exercise limitation, and then pass the mic to Prof. Rez to see how he's layering on the fever. And I think that whenever patients describe a subacute reduction in their exercise capacity, what we're trying to do is we're trying to take the dyspnea pyramid and we're trying to see, well, how can we adjust it such that the time course is chronic? And I think that it goes to show you that it is actually pretty unusual to get chronic pneumonia. It's pretty unusual to get chronic heart failure. And so some of the things that you're used to in the landscape of shortness of breath, acute shortness of breath, are different. So what are chronic cardiac causes of exertional limitation? I think the most common one is coronary artery disease, followed by structural heart disease that doesn't necessarily develop into heart failure. So aortic stenosis and pulmonary hypertension are lead examples. And then within the lungs, I think interstitial lung diseases are defined by their long-standing time course. And so if you ask yourself, what are the most common causes of pulmonary causes of reduction in exercise capacity, it's usually obstructive lung disease like COPD and interstitial lung diseases. So I think those four things explain the vast majority of patients. Structural heart disease like aortic stenosis and pulmonary hypertension, coronary artery disease, interstitial lung disease, and COPD. Which of those can have an acute exacerbation such as this? I think that it would be pretty unusual for a heart condition to flare up like this without overt heart failure. It would be pretty unusual for coronary artery disease to flare up like this. And so I think chronic diseases that result in shortness of breath that can flare are more often pulmonary in origin than they are in cardiac. And so that's what I would do with that dimension, but I'm really curious what the fever does for you, Prof. Rez.
I think what I really appreciated briefly, Robbie, about your discussion was just talking about like something that might be chronic, but eventually it lands and crashes and the patient presents. And we've talked a lot about that concept of symptoms brewing subclinically and then eventually coming to the surface, where we may mistakenly categorize the tempo as acute or hyperacute, but in reality, it's been going on for some time. I think what the fever does for me is one of two things. it suggests that there's underlying inflammation, and then prompts me to consider first and foremost infection, and then less common etiologies, the cancers and the autoimmune processes. But I just have to be very careful here, because the two ways I'm framing this problem is either that chronic respiratory process has made this person vulnerable to a new disease entity. Like you mentioned, someone with COPD at risk of pneumonia. Or is that subacute to chronic process finally showing its inflammatory signature in the form of a fever? Because remember, fever is just one dimension of inflammation. There's a possibility that there is low-grade inflammation that has yet to surface. So I think the only way we can make progress on this is to get the background data, get the physical exam, get some labs to see, where are we going to anchor ourselves in the primary site of pathology. I know it's not much to take, but I think we just need more data to make progress. It's either the fever is related to this because it's the primary cause of the fever, or the fever is related to this as an independent process, or the fever is related to this because the primary process made the patient vulnerable to a second hit that's unrelated to the primary process. VJ, back to you, my friend.
Okay, such a rich discussion. So I think past medical history, the patient was diagnosed as chronic kidney disease, stage 3. Based on a biopsy, there was an unexplained AKI. Biopsy read chronic tubulointerstitial nephritis. At that point of time, the ANA, ANCA, and all the serologies were negative for the evaluation of CKD. Patient has been on conservative management. However, in view of the biopsy showing high amount of crescents in the beginning, so she was treated with a short course of steroids for about 3 months. So this is about 4 years ago. Apart from that, there is no significant so medications. She is on telmisartan for hypertension. That's it. So family history was not significant. Social history and health behaviors, none of which is significant. I'd go to the vitals. So when I saw this patient in the clinic, so the BP was 170 over 110. Heart rate was 78 beats per minute. Respiratory rate was 20. And so saturation was normal, 98% on room air. Dental physical examination was unremarkable. There is no clubbing. Chest was clear, normal breath sounds. Abdomen was normal, no focal deficits. So physically, it was a normal exam. I think I'll stop here.
BJ, so helpful. Maybe I'll comment a little bit on the background data and then hand the mic to Robbie to layer upon that and then incorporate the physical exam. And one other thing that I thought about, Robbie, when you said, what does the fever do? If the fever and shortness of breath occurred simultaneously, I would activate the inflammatory thoracic syndrome schema. But because they're occurring so distantly, I'm not prioritizing that schema to say, oh, it must be the heart, it must be the lung, it must be the mediastinum. I'm open to other sites of inflammation. The background data is very intriguing because this person is quite young without a significant history that would cause accelerated kidney disease, right? Like they're 46, they don't have a background of diabetes. There's no hypertension, though I know that's debated whether it's the cause or the consequence of kidney disease. So it tells you that biopsy was critical And I'm glad that you did that. Even in your patients with diabetes, rather than pinning it on the diabetes, those patients really do need a biopsy because a good portion of them, it's not diabetes leading to kidney disease, but it's another process that you may be able to intervene upon. I just want to briefly talk about what they saw in the biopsies. One was the crescents, and the other was a tubular interstitial disease entity. You see, we all have a good framework for AKI. We say pre-renal, renal, post-renal. If you want to take that a step further, you can develop a similar framework for intrarenal AKI. And I have to pause there briefly. Why do we care so much about diagnosis? Think about it. The earlier you diagnose something, the more likely you are to prevent irreversible damage. Robbie presented a case on RLR of this poor guy keep coming to the ED who had thiamine deficiency, initially had Wernicke's, and then had Korsakoff, and then had irreversible neurologic injury. So the whole point of what we're doing here in VMR and our whole mission in CP Solvers is to equip you to make diagnoses as early as possible to prevent irreversible consequences of diseases. And I bet you this CKD, if diagnosed early and the etiology identified, there's a good chance you prevent its progression. For intrarenal AKI, I want you to picture the glomerulus, the tubule, the interstitium, and then the vessels that run along it. And those vessels that run along it is where you can have stuff like sclerodermal renal crisis, APLS, TTP, HUS, etc. But the main focus here is the glomerulus, the tubule, the interstitium. And you can see already what Vijay is teaching us is that oftentimes there's not just the tubule, not just the interstitium, and not just the glomerulus, but there's this sort of overlap of disease that's affecting each part. If you just focus on the interstitium, when we have interstitial nephritis, the 3 buckets to consider is medication, look for that PPI, look for that antibiotic, infection, and infection is usually from pyelonephritis as a common cause to tuberculosis, and then look for autoimmune diseases. And those autoimmune diseases are your S's, your Sjogren's, your lupus, your sarcoid, and then just throw it in IgG4 related disease. When you get to the tubules, the most common cause of tubular pathology is acute tubular necrosis, right? And this is where having a urinalysis and having the sediment is very helpful. But other etiologies include pigments, crystals, proteins that can go and clog up those tubules. The crescents here for me, like when I think of crescents, and I don't know if this is right or wrong, but it translates into glomerular pathology and rapidly progressive glomerular nephritis. And if you're at the level of the glomerulus, you either think of an immune complex mediated process that depletes complement like lupus, or one that doesn't deplete complement like IgA nephropathy. Then you have ANCA-associated vasculitis, and these are your posse immune, meaning when you do your immunofluorescence, you're not seeing much light up on that immunofluorescence. And then you have the anti-GBM. So what I'd like to do now is I'd like for Robbie to actually layer upon that and see if he can link it to the shortness of breath, or if his mind is even doing that, whatever he wants to talk about. But for me, I would be making sure if I was reviewing this person's history, I would be like, all right, did I rule out all the glomerular nephritis with labs, etc.? Did I think about all the interstitial nephritis and what diagnoses overlap there? It may also involve the lung.
Prof, that was such an incredible discussion and the walk through all the causes of tubular interstitial nephritis, and the caveat that I share with you too, that like the finding of crescents leaves us a little bit on unsteady ground. Is this a glomerular disease too, or tubular interstitial disease? I think it's all very interesting, but but what I find super intriguing is it's amazing to see the HPI to the left of the exam, and to see how dominant the HPI is. The patient's short of breath, she's coughing, she's febrile, and then to see the gentleness of the exam, and that the exam is really, and I'm just trying to picture this person, you know, when the information coming into my ears is, doctor, I'm really short of breath, I'm coughing, and I'm having fevers, and then when I use my eyes I don't see much. And I think it just goes to show you that pay close attention to the details of the HPI are really important, because what she's really saying is that she has shortness of breath when she walks. She's not saying that she's has shortness of breath at rest. So I think it would be very, very powerful to see what happens to this person if she were to exert herself, and to see, does her respiratory rate go up, does her O2 sat go down. And so in our initial framework of heart versus lung as causes of shortness of breath, I think as soon as the exam is negative, you have to wonder for a moment, well, is this an extra thoracic cause of shortness of breath that she's having? And is she anemic or acidotic or something like that? That would be the first thought. But then, of course, that thought implies that the patient's, that the data that we're using right now to make inferences about the heart or lung is perfect. And of course, it's not. The ability of the examination to detect cardiac pathology and pulmonary pathology is quite limited. And so if you're making a simple schema for exam negative shortness of breath, it would be, okay, exam means true negative shortness of breath, prioritize anemia. But then what kinds of things can slip under your radar on exam? Coronary artery disease is not detectable on exam. That's probably the only cardiac cause, honestly, because aortic stenosis, pulmonary hypertension, pericardial effusion will all leave some signature. That signature may not be robust. You may not be able to be like, what's that heart sound? Why does it sound so weird? Is that JV elevated? But you'll get a flavor enough to be at least a little bit suspicious. I think also in terms of the lungs, it'd be very hard for an obstructive lung disease to hide on exam, and the absence of wheezing is very telling. But subtle interstitial diseases can certainly do so. And so I think what else is crossing my mind too is not a disease in the heart or the lungs, but actually a disease process in between. And something in the mediastinum could easily cause exertional shortness of breath and a dry cough that may not be detectable on exam. So I'm really, really curious to see how we're going to correlate the shortness of breath. Is it cardiac in origin? Is it pulmonary in origin? Is it mediastinal in origin? Or is it anemia? And I think all those things are at play. So I think to summarize the progress we've made on the HPI, I would say that a cardiogenic cause is less likely because there's no evidence of heart failure. A coronary cause is less likely to begin with in such an inflammatory presentation. And so, so I'm suspicious of either a pulmonary problem that has evaded our detection on exam, or a mediastinal problem, which is very hard to detect on exam, like mediastinal lymphadenopathy, but would be very, very open to the idea that the shortness of breath is completely non-thoracic in origin. VJ, we're very intrigued. What do you have in store for us next?
Amazing discussion. So I have a basic set of labs. So her hemoglobin was 8.6 with a baseline of 11.5 in June 2024. With an MCV of 88. Total counts were 4,800 with normal neutrophil of 78, lymphocyte of 12. Platelet was 5,14,000. The peripheral smear was suggestive of normocytic normochromic anemia. BUN was 44 and the creatinine was 4.8. The baseline we have 2 months back was 2.8. And the most recent creatinine prior to this has been having a gradually rising trend in the past 2 months. The bicarb was 18. Glucose, calcium, magnesium were normal. The sodium was 128. The potassium was 4.8. AST, ALT, alphos, liver chemistries were normal. The coagulogram was normal as well. I would leave it at this. A urine microscopy did not show any protein. The urine microscopy showed 1+ protein with a 24-hour protein was 258 mg with no active sediments or any RBC casts or abnormalities.
Yeah, I think Vijay, I think this is very interesting. Maybe I can pass the mic to Prof. Rez for the kidney dysfunction and just reflect on the CBC, which is that there's an interesting dimension to the CBC, and that is that their patient has anemia and thrombocytosis. I believe the patient's platelet count was 540,000, which is high. And so I think you have enough explanation for the patient's shortness of breath, I believe, with the possibility of nephrogenic pulmonary edema and symptomatic anemia. But I think you wouldn't want to skip over that because there can be very subtle parenchymal or mediastinal findings to suggest the patient's mechanism. So it might be tempting to say, oh, I found anemia, a hemoglobin of 8.6, so that accounts for the patient's shortness of breath. But I think you could easily overlook a subtle cavitary lesion in the right upper lobe. You could easily overlook mediastinal lymphadenopathy. So I'd still be interested in examining the pulmonary fingerprints of this disease process. And I think I'd be interested in examining the pulmonary fingerprints, not just because of the limited sensitivity of the exam, but also because the patient seems to have a systemic hectic syndrome. And I say that because of the fever and the thrombocytosis. And so here, I think there's two ready explanations for the anemia. The first is that it's obviously in the context of kidney dysfunction, but also in the context of inflammation. And so I think the simple things to make sure you're not missing are to get iron studies, and to Prof. Rez has received some wonder. Oh, I have Prof. Rez, you got to tell us who you're bumping into. This is so cute. Okay, I'll just finish up real quick. And then making sure that we get a serum paraprotein analysis to make sure we're not missing a paraprotein. Prof. Rez, who'd you just meet?
Dude, I'm so sorry that my brother surprised me.
Oh,
My brother lives in
no
DC,
way.
and his dog, Robbie. This is Frankie right here.
Hi, Frankie. Hi, Frankie. Oh, Frankie's so happy to see you.
So Robbie, I just wanted to clarify something with
Yeah.
BJ. BJ, is the calcium level elevated, or is it, what was the calcium?
I will give just the labs of even the calcium, phosphate, and vitamin D as well. The calcium was 8.6. The corrected PTH was elevated at 104. The vitamin D was 54 and was normal.
I understand now. Okay. Thank you so much.
Ultrasound abdomen showed normal kidney size as well.
Okay. Thank you, Vijay. Like, someone knows medicine when they're presenting all the data that you want, as Vijay is doing here. And maybe, Robbie, we can just like bounce back and forth really quickly. Like, I looked at these labs, and if this patient's creatinine was 1, and now they're presenting with 4.8, and there's no other area of pathology, and they're not floridly septic, hypovolemic, then my focus would be the kidneys. Here, I'm still focused on the kidneys because of the background, but it's important to note that we were starting at a vulnerable state. So it's not going to take much to push someone from 2.8 to 4.8. So just the same way you said you're open to an extrathoracic process, I'm open to an extrarenal process driving this presentation, but I'm going to still think about the kidneys because of the background data. I think it's just really important, like everything is relative to what it was, not just an absolute value. This is a very important principle in clinical reasoning. And what I'm going to try to do really quickly is explain a lot of these findings just through kidney pathology. Because remember, where is erythropoietin synthesized? It's synthesized in the kidneys. So a lot of times we see patients, even with acute kidney injury, having an anemia because they don't have erythropoietin to stimulate the bone marrow to produce red blood cells. The sodium of 128 is expected in someone with CKD, where they have difficulty maintaining body fluid homeostasis, and therefore their sodium tends to drop. PTH should be elevated in chronic kidney disease because as the kidneys are injured, they have difficulty with activating vitamin D, which means they have difficulty with calcium homeostasis and phosphate homeostasis, leading to secondary or tertiary hyperparathyroidism. The size of the kidneys, if small, is really helpful because it's the biggest clue to chronic kidney disease, but their normal size is not helpful to exclude CKD because it might be a little bit larger due to the underlying pathology at play. Really, what surprised me here, Robbie, with the laboratory data, the proteinuria is telling you that you're having spillage, and it's in that range that's enough to irritate you, but isn't slam dunk that we're dealing with the glomerular process. That is nephritic range proteinuria. It's not nephrotic, but it's not less. And the UA not having red cells or white cells doesn't really do anything for me except say, oh, this can be IgA nephropathy. It can always be IgA nephropathy. You can always say that on rounds and you'll always be right. But it could still be a glomerular nephritis. It could still be tubular interstitial. In fact, interstitial nephritis may have 0 white cells or red cells in the urine. Or it may be glomerular and you just didn't catch the urine when the glomerular spilled the red blood cells into the urine. But really the thing that surprised me the most here, Robbie, is the vitamin D level. I would ask this patient if they're taking vitamin D as supplementation, because we just said the kidney plays such an important role in vitamin D activation. This level is probably the 25 vitamin D. That's the level that we measure, but it's so unusual to have that level be quite elevated. So I'd ask, are they supplementing or not? And is this an issue with vitamin D? But when we think of those granulomatous processes, they usually decrease the total vitamin D and they increase the 125D. So I don't know, the vitamin D is there, it's in the background. And I'll tell you where I'm at with this case. I personally think that the issue is at the kidney because of the background data. I think it's an inflammatory process. I think we have to explore what's causing this nephritic range proteinuria. But it wouldn't stop me from getting cross-sectional imaging of the thoracic cavity and sending a pro-BNP, for example. But I got a bit distracted as I was surprised, but I would love to give the mic to you to summarize where we are and where you're at.
Yeah, Prof. Rez, I think that's an absolutely superb summary. And I think the way you entered it is exactly excuse me, where I'm at. Is I think when we heard of a really long-standing issue affecting the patient. And the symptom that we heard was shortness of breath. So we went to the thorax. And then in aliquot number 2, we actually got a context that is in the abdomen, the kidney. And so now we're at a tension point of, wait, the labs tell us the kidney is on fire. Do we just commit to this whole problem being a kidney issue and ignore the data on the first aliquot? And I think I agree with you. I think that would be a mistake because the prominence of her shortness of breath and the localizing value of her cough mean, I think, that while the ultimate explanation for her shortness of breath and cough may be non-specific manifestations from the consequences of kidney dysfunction through anemia, through other mechanisms, I too, like you, would be cautiously approaching this as a pulmonary renal syndrome, but not in the form that is commonly intended. I think when people say pulmonary renal syndrome, they often mean diffuse alveolar hemorrhage and glomerular nephritis. I think this could be a classic pulmonary renal syndrome, but we may connect the dots of pulmonary and renal through other mechanisms like tubular interstitial disease and cavitary lesions, or tubular interstitial disease and lymphadenopathy. So I'm really curious to try to clarify the subcategories of the 2 organs involved. And I think that'll allow us to make a lot of progress. All right, Vijay, what do you have in store for us next? Such an
I'll
intriguing.
just share the CT. I think that was helpful for us. I just gave some clues. Is my screen visible?
Yes.
Okay, I'll just scroll through the image. So this was a HR cut of the lung window.
Robbie, a lot of ground glass opacities, you agree?
Yes.
And maybe a little bit of bronchiectasis.
I wonder if they have a nodular component.
Yes, 100%. If you go back up, VJ, looks like a mass is almost there in the lungs.
No, I'm trying to. I'm not good at. Yeah, right. Yeah, there you go. Yeah, thank you, VJ. That cut is really good. Trying to figure out. When you hear nodules, Prof, Raj, you're always trying to figure out what the pattern of the nodules are. I couldn't quite decipher that honestly. But
No,
yeah,
the CT read was so we didn't go for a radiological interpretation because we had to take a decision. So given the dropping hemoglobin and this presentation and some bronchiectasis, so we are concerned for two things. One is infections because tuberculosis is very rampant in India. So we're very concerned about that. And we're also concerned about coexisting pulmonary renal syndrome. So we repeated the urine analysis because we were having a suspicion. So the repeat urine showed 60 RBCs and 2+.
Woo! Who told you guys to repeat a UA like you repeat a troponin? You heard it first on RLR. Sorry, BJ, I'm not happy about that, but we've been saying that for years now, and it finally comes to fruition.
Amazing. So after this, we went ahead with a bronchoalveolar lavage. So it showed a frank DAH in the ball. However, the ANCA serologies initially sent, the ANA and the initial C ANCA and P ANCA sent were negative. So I think I'll leave it at this.
yeah, and I think
Yes, Robbie, you're up.
yeah, I think this case is so humbling because you can see how subtle those pulmonary findings are and how hard it might be to detect those pulmonary findings with your stethoscope. And so I think getting clarity on the kinds of things that can hide in the lung and evade the stethoscope and even probably potentially evade the CT scan is really key. And so maybe Vida, I can just clarify with you because I'm not a radiology expert, but the findings that you had on your interpretation of the CT was that there were those bronchiectasis and what else did?
Okay, it was more of GGO. There is a consolidation that is surrounding GGOs, predominantly in the right upper and middle lobe. And however, if you see very carefully, there are also the diffuse pattern of GGOs in bilateral lung fields, and predominantly it was surrounding the cardiac, so paracardiac.
Yeah.
So this was our interpretation. Maybe a probable halo sign, like Mark said.
Yeah.
But given the bronchiectasis in and around that place, we were not very sure of the halo. But this is what this was
Yeah.
our interpretation of the same.
Interesting. So diffuse GGOs and a pericardiac pattern along with bronchiectasis is a very interesting combination of findings, I would say. And so maybe I can reflect on that dimension and the DH and then ask Prof. Resh to see how he's synthesizing it all. But you may ask yourself, so what is diffuse alveolar hemorrhage? I think this is a really important point to try to clarify. And to understand diffuse alveolar hemorrhage, you have to understand what gravity does to the lungs. So how is diffuse alveolar hemorrhage diagnosed? It's diagnosed by seeing in different segments of the lung that you get serially bloody return. So you inject, and every single time you get bloody return. Now you may ask yourself, like, why do I need to do that to prove that there is diffuse alveolar hemorrhage? And it's really because of one reason and one reason alone, is that bleeding in the lungs can move. So if you bleed in one segment of your lungs and you're having ongoing active bleeding in one segment of your lungs, that blood can drop and move because of gravity into all other parts of the lung. And so if you find blood in a segment of lung tissue, you don't know if it originated there or it ended up there through passive gravity. And so the way that diffuse alveolar hemorrhage is diagnosed is if you assume that, okay, if I inject some sterile saline and this was just blood that moved over there from another source by gravity, I'll be able to thin it out. And so it's a very common tension when we're taking care of patients where they have blood in multiple places, and you actually just realize that they have a focal source of bleeding, and the reason they have blood in the other place is because it dropped there by gravity. But if that were the case, if you were able to inject saline and return back, then it'll become less and less and less bloody. So by seeing in multiple different parts of the lung that there is a bloody return, you've not diagnosed a diffuse bleeding process, i.e. diffuse alveolar hemorrhage. And so, what is the differential diagnosis of diffuse alveolar hemorrhage? In stark contrast to what Prof. Rez will share with you more about, the differential diagnosis for diffuse alveolar hemorrhage is much more than just vasculitis. So the presence of concomitant glomerular disease markedly limits the differential diagnosis. And unlike glomerular bleeding, which has a very narrow differential diagnosis, alveolar bleeding is much more broad. And the reason for that is the lungs are exposed to the world much more so than the glomeruli are exposed to the world. So you'll see things like infections, like leptospirosis and strongyloides. You'll see things like cancer. You'll see things like just the mere effect of heart failure and elevated pulmonary venous pressures. So there's two things here. How do we diagnose diffuse alveolar hemorrhage? Just like VJ did with serial aliquots that are bloody in multiple parts of the lungs. Why do we need to do that? To rule out gravity causing blood moving. What is the differential diagnosis of DAH? Unlike the differential diagnosis of glomerular bleeding, the differential diagnosis of DAH is much wider and includes bread and butter things like bleeding from medications, bleeding from heart failure, bleeding from infections, bleeding from cancer. Vasculitis is a small subset of diffuse alveolar hemorrhage. But we might make progress in that direction in large part because of what Prof. Rez anticipated. And so I'll pass the mic to you, Prof. Rez, to share more.
Robbie, I think that's so well taught regarding diffuse. I've never thought about it like that. Why do we do like those multiple lavages? But that was expertly taught. For me right now, I think the kidneys are the primary site of pathology. And this story didn't just start 20 days ago where there's inflammation. This story started years ago when this patient had that kidney biopsy where there was evidence of local inflammation. And maybe at that point, it was a renal limited disease entity, but now it's expanded beyond the kidneys. But here's the challenge I have, Robbie. I don't know if this patient was made vulnerable because of their kidney disease, because we know with kidney disease, your immune system is down. Or were they made vulnerable because of their underlying autoimmune disease that's affecting the kidney? And now they're getting a superimposed hit in the lung, and we're seeing that. Or is this really something that started out as renal and now it's connecting to the lung? It's that the whole ABC thing. Is A causing B? Is A and B independent, the kidney and the lung? Or are they connected through C? ABC. 1, 2, 3. That's like, keep it simple, stupid. KISS. So I think for me right now, my entire focus and intention is going to be looking for an infection, particularly atypical infections. Like when you say nodules, my mind automatically goes to tuberculosis. It goes to endemic mycoses as possible etiologies in that infectious bucket. And it also goes to cancers like lymphoma or things that may spread to the lung. But the branch point one is this infection or not? And you have to be cautious because a lot of times nodules that are affecting the lung don't find their way into the airspace. So even if you do a BAL, it may be negative, but really what you need is a biopsy of one of those nodules. Here with the ground glass opacities, I think whatever disease is involving the lungs, you're going to find its way into the airspace. So from the pulmonary standpoint, I think looking for atypical infections, sending the PCRs if you're able to, the culture data, the stains, TB, fungal infections. But from the renal standpoint, doing the electron microscopy, light microscopy, immunofluorescence, and resending the antibodies, because remember, some patients with ANCA-associated vasculitis don't have ANCA-positive serology, especially if it's renal limited. When it's more diffuse, more likely the ANCA is going to be positive. And I learned this from you, Robbie. Of those ANCA vasculitides, NPA is the one I think that is more likely to cause the nodules. But GPA can cause masses. And nodules versus masses just based on the size, like petechiae versus purpura. And we're not radiologists to label it, but the radiologists can. I would love to know from you, Robbie, is there any Are you leaning towards anything specifically at this time point, or is it more rule out infection, reassess for possible autoimmune diseases like lupus, and go from there?
I think that's Prof. Rez, I have nothing to add, but just to emphasize what you said. I think that the fact that you have DAH with hematuria and nephritic range proteinuria, I think really restricts the differential diagnosis to ANCA associated, well, I should say posse-immune diseases, either ANCA positive or ANCA negative. And then there's a very few immune complex diseases that cause both, with lupus, IgA nephropathy, your favorite diagnosis, and cryoglobulinemia. And I think that you know, an ANA would be an easy check to do, but the thrombocytosis would be relatively incompatible with lupus. And what's really, really interesting is, of course, the wondering whether this could be Goodpasture's disease, anti-GBM disease. Anti-GBM disease is certainly possible, but the classic description of anti-GBM disease would not include anything but DAH and glomerulonephritis. So it would be pretty unusual to get thrombocytosis, and it would be pretty unusual to get bronchiectasis. So if you have those three categories of posse-immune, lupus, and Goodpasture's, I think you have to strengthen the posse-immune, even though the ANCA is negative, because Goodpasture's is possible but doesn't usually feature bronchiectasis or thrombocytosis. Lupus is possible but doesn't usually feature thrombocytosis. And then the sneaky aspect of the posse-immune is only 70% on average are ANCA positive. GPA is very likely to be ANCA positive, about 90% of patients with GPA. But when you have a renal predominant presentation initially, followed by a pulmonary presentation that features bronchiectasis, I think the diagnosis of MPA becomes much, much, much higher. So that's probably what I would be most suspicious of, is microscopic polyangiitis. But I think the question is, how do you make progress? And I think you can repeat the ANCA serologies for sure, but I think tissue is the issue. And that's where I'd love to get your take here, is if you were the general attending for this person, would you advocate for looking at the lungs, looking at the kidneys? And I don't have a good answer to that. So I'm really curious what you're thinking about where you might get tissue from.
I love that question so much. It's almost like when you have that patient with metastatic cancer of unknown
Yes.
primary, you're like, where should I biopsy? And you end up biopsying the site that's easiest to biopsy, meaning less complications, and the site that's most likely to give you an answer. And I think in this case, I mean, we always joke about this, Robbie, like, would we give a gram of methylprednisolone? If you recall, I think I'm 1 for 3 on this. Last time I gave it to the patient who had endocarditis. So always think about endocarditis, folks. Are those septic emboli? And is that the end? But I honestly think that I would probably go for the kidney. It's easy enough, and it should give you the answer. And the story started in the kidneys. I think the lung, you would have to talk to an interventional pulmonologist to see if you can do an EBUS biopsy or a percutaneous thoracic biopsy. But for me, I still think it's really important to rule out infection, because people with autoimmune disease are compromised immune system, and they may have a super hit on top of their autoimmune disease. So I think you still got to rule out TB and endemic mycosis in this patient before being aggressive with the $1 billion of immunosuppression.
Oh, good thing we have an expert pulmonologist to help us navigate the case. How did you decide to proceed?
So we thought kidney was the easiest site to biopsy. We're just worried because there's a DH. We're just concerned about the bleed. So we went ahead with the kidney biopsy. So the kidney biopsy was suggestive of a focal segmental glomerulosclerosis. Interestingly, we repeated the ANCA serologies. However, we sent the PR3 and the MPO antibodies instead of just the ANCA. And that came out strongly positive for PR3, which was 56. The cutoff titer was 56. So we went ahead with giving steroids, a pulse steroid, and we started the patient on cyclophosphamide. I just saw the patient now. Unfortunately, after giving cyclophosphamide, the patient has landed up with a suprahepatic infection and an ARDS and is admitted in the ICU. The only take home for me in this case was the patient had been roaming with a diagnosis of vasculitis and unexplained CKD. So the disease just we're just lucky that the disease manifests in the form of fever, and we could just diagnose it. BAL cultures, the secondary cause of DH, all of the BAL reports were inconclusive, were all negative. So I think ANCA testing is very crucial when you're in doubt. I think repeating the urine and repeating testing of the ANCA, especially antibodies. So I think that is very crucial rather than sending an immunofluorescence, because most labs may or may not have the expertise for interpreting immunofluorescence.
Oh, Vijay, I think this is such a twist on something we talk about in VMR. I don't know if I've ever heard on VMR a case of GPA or ANCA associated vasculitis that's been happening for years. And for it to take off in such an abrupt and aggressive way. But I think it allowed us to make so many bread and butter learning points, and some of the original learning points that Prof. Rez made on the very few first episodes of the podcast about repeating and trending the UA. That was a key piece of information here. I learned a lot. And I can't imagine how tough it was to diagnose this case, because you easily could have phrased it as tubulointerstitial nephritis and moved on. But I think the crescents that were left on that initial biopsy turned out to be really important and not to be glossed over. Thank you so much. Really, really educational experience. Your thoughts, Prof. Rez?
Yeah, I too want to just echo what Robbie said. DJ, you are one of my heroes, man. You just finished the shift. You present this incredible case. And something I learned from you on this case is that inflammation can sometimes be subclinical. You know, we always talk about fever. That might be the most specific finding, but it's not the most sensitive finding. And Robbie, I recently had a patient with like lupus nephritis that went undiagnosed for 6 months, unfortunately. So it's just really interesting to see. And again, like the power of clinical reasoning is exactly this, where you think about it. So DJ, thank you so much. I would love to hear from Julia. Thank you all. That was a lot of fun.
Hello. I am mind blown by the discussion, to be honest. Thank you so much for presenting this case. And there's a lot to learn, to reflect. And I thought it was really a journey of localization and putting all the puzzles together. And we had so many symptoms more leading to the lung, to the kidney, and how to connect it. Or I love your concept of like A, B, and C, and really trying to understand what is definitely like the underlying disease or causing and influence the other. That is brilliant. So thank you so much for letting us participate in your train of thoughts. So we really started off with long-standing shortness of breath. And what Robbie emphasizes is that like a rather acute reduction of exertional capacity kind of led us to think about two separate processes, but it's more unlikely that a non-inflammatory progress is suddenly progressing in an inflammatory. But also we should keep in mind what Prof. Rez taught us, that we can be fooled by relying on that information to narrow down like a chronic, a subacute, or an acute process, because there can be like smoldering symptoms of a chronic disease that just like flare up suddenly. So we should be careful, like just jumping into that pathway. However, like the most common causes of reduction of exertional capacity I learned are either like pulmonary or cardiac, where the pulmonary one are COPD, interstitial lung disease, and the cardiac one are rather structural problems or CAD. If we think about chronic diseases that tend to flare up, we would more go or dive into pulmonary causes rather than cardiac ones. Our patient had a pertinent history of accretions on biopsy, so we were diving again into like intrarenal AKI causes, and that was like a brilliant roundup of all like different causes of intrarenal AKI that Prof. Rez gave us. And I love this anatomical approach, thinking about the glomerulus that can be immune complex disease, where the complement can definitely help us to narrow down our diagnosis with SLE more being low or IgA being normal, ANCA vasculitis, or anti-GBM disease. If we think further down, we can also think about the tubules, the interstitium, and the vessels. Then we kind of to go step back and think about the exam negative courses, like courses for exam negative shortness of breath. And in our patient with an acute and chronic disease progress, we can think about like more subtle interstitial lung diseases and mediastinum diseases more than anemia or CAD, because they don't tend to be like abruptly acute. With nephrogenic pulmonary edema and anemia, that can be an explanation of shortness of breath. However, we had a systemic fingerprint in our patients, so we should really think if it's an explanation enough and also dive in all this systemic fingerprints like anemia and thrombocytosis. Also, like a very helpful bread and butter teaching point that I love to being reminded today was any hints for a chronic kidney disease. So thinking about the size of the kidney, anemia due to a low EPO, also like an elevated calcium due to secondary or even tertiary hyperparathyroidism. In our patient, it was an interesting clue that he had an elevated, or sorry, she had an elevation of vitamin D levels, which is kind of inconsistent with like a chronic kidney disease because of a reduction in 25-hydroxylase. However, we should like just dive into the history again. Then Rabih taught us about DAH and this nice pathophysiology about like how to diagnose that one. To think about like any blood in the lung can move with gravity. So to diagnose this disease, we need like a serious bloody return in lavage rather than, or to distinguish us from a focal source of bleeding. In the end, we tried to put all the symptoms together, and I only want to mention one last teaching point I find great was our lab findings suggested things like lupus, IgA, or cryoglobulinemia, but we always have to connect it with like all the information we have. So, for example, the thrombocytosis are not very consistent with that. So in the end, putting everything together, there was a GPA-associated vasculitis, and I'm just like mind blown by how you got there and how you conceptualize all your thoughts. Great. I'm very grateful to be part of that. Thank you.
What an incredible hour, y'all. Johan, thank you for scribing, and hopefully it's closer and closer to dinner time in Barcelona. Vijay, an absolutely incredible case. Thank you so much for all the learning that came along the way, the bread and butter and the esoteric, and also just outlining the challenges that are inherent to diagnosing these conditions, the false negative serologies, the biopsy with imperfect results, the ease of glossing over her respiratory symptoms and not doing so, and just how crucial the DAH was, the only ultimate objective evidence of vasculitis. So the subtleties were really, really cool here. And then last but not least, Julia, for you to capture all of that and articulate all that was outstanding. And last but not leastest, Prof. Rez, who I think bounced to hang out with his brother. Great week this week on VMR, y'all. Hope you have a fantastic rest of your day, and we'll see you next time. Bye.